nurses in our unit identified that they had a hard time taking care of suicidal and self-harming patients that survived to come to the ICU. And so we didn't have to worry about getting buy-in from our staff. They were asking us to take this on.
What's behind this?
As a bedside nurses, we knew that it was difficult to care for these patients, and not only for them, but also for their families. There are times that we treat them and they're ready to be transferred, but unfortunately there is a limited number of psychiatric beds in the area. So they stay with us for a while, and they are on one-to-one observation, and that made it really difficult. Nurses sitting in that room, the environment is really not suited for suicidal patients, and you're like, what do I say? Do I say anything?
Right.
The room is dark. They don't want to eat. They don't want to look. They don't want to, and they feel the same thing.
Oh yeah.
They're like, I'm the burden. Nobody wants to take care. They're judging me for what I did.
Why doesn't my nurse want to talk to me?
Well,
right?
and then think about it. They feel, okay, they're already hopeless.
Everybody's thinking that,
You loser.
Exactly.
I'm a loser.
And one of our focus was that smile, be non-judgmental when you walk in the room. Don't care why they're here. Find something they like. If they said about their pets, use that for the rest of the shift to engage them in a conversation that makes them happy.
I think one of the worst things is to, you don't want to trigger something to make it worse
Yeah.
than it already is.
Exactly.
And,
Exactly.
and sometimes silence is okay.
Yeah,
Just
definitely.
be accepting.
And some will let you know that they don't want to talk, and you can't force them to talk.
You can't.
Absolutely. What to say? Is it appropriate to ask a question? Do I answer if they ask me any questions? So these were the questions that our staff over and over had brought up, and we felt that it was the best time for us to take on this project and give them the tools and equip them so they can care for these patients, so we can know what to say, when to say, how to prepare ourselves, and improve the care that they receive in the hospital setting. And this is non-psychiatric pediatric intensive care unit, but it can be implemented in any parts of the acute care hospitals.
The first part of our project was to look at the evidence in the literature. And so when we started looking at what are the incidents of suicide completion and attempts, what we found is that suicide at 17.6% is the second leading cause of death for American youth, which is comprised of kids aged 10 to 24. Second leading cause after unintentional injuries. As scary as that number is, that's not even the patients that we're worried about, because those kids usually don't make it to us. The patients that we were concerned about were the kids who survived their attempt, and being able to medically stabilize them, and then, as Ferry was saying, provide a therapeutic environment as they're waiting to be placed in an inpatient facility. And so when we were looking at the numbers, the National Youth Risk Behavior Survey is conducted every 2 years. It's a self-report survey done by high school students in 9th through 12th grade. And one of the things that they found is that 2.4% of students will make a suicide attempt that requires treatment. So these are the ones who survive to be treated by a physician or a nurse, which is pretty scary when you think about how many kids in that age range there are in the United States. And looking at this survey report is that 2.4% survive, but that 7.4% attempted, that 13.6 actually made a plan, and that 17.2 were thinking about suicide. And then perhaps even more startling is that 31.5% of these students felt so sad or hopeless for greater than 2 weeks that they stopped doing their usual activities. And aside from work, I don't think I know 100 kids in grades 9 through 12, but when I think about 32 of them feeling that sad, it makes my heart stop a little bit.
We also wanted to look and see what was the perception of the nurses. When we did the literature review, we found that there was a lot of misconception about this topic of suicide and self-harm. Well, you hear it, that patient is acting that way, they're trying to seek attention. We hear that a lot.
They're trying to be manipulative.
Or they are trying to be manipulative. We tried to look and see what is our own staff's perception of the topic. And then when we did a survey, we found that yes, there were areas that were staff having misconception. So we made sure that we had education prepared to kind of clarify some of the misconceptions and put the facts out there. We also tried to look into what is it that helps us build that therapeutic relationship. So we made the use of the simulation. That helped us a lot. The staff felt that being able to role play, giving them scenarios and then discuss the points and give them suggestions, which came from our psychiatric team, was huge. They really liked it. It gives us those tools that we felt that we didn't have. We didn't know what to say, what to do, but now we feel a little bit more prepared for it. Another aspect of this project was that we collaborated with our other teams. Psychiatric team was very influential in developing these therapeutic sections and doing those simulations that we talked about.
I like the role play. Did you ever have the nurse play the role of a patient?
The social worker on our psychiatry team wrote some simulations for us, and we actually did. We devoted a period of time to do these role-playing scenarios in our skills fair, which was huge, because we don't know how many of our nurses have dealt with suicide or self-harming youth in their own lives. When we look back at our numbers, like in 2015, we only had 4 of these types of patients admitted to our unit, and in succeeding years, we've had like 14 to 18. I mean, that seems like a big jump, but even then, it's only like 1 or 1.5 patients a month. It's not a high frequency admission, but it's very stress-inducing for our nurses. And then to be able to even have a time to practice so that they can strengthen their skills before they're in a real-world situation was very helpful for them. We got a lot of feedback from our nurses that it was really uncomfortable, like the idea of looking at someone and role-playing, how they would interact with a suicidal or self-harming youth. It's uncomfortable. People felt very awkward, like they were worried about what if I say or do the wrong thing that's going to make them feel worse, or and these are very real fears. But even just providing the opportunity for them to practice in a safe environment, and then to have discussion points on validating that sometimes life is rough. Kids have stressors that at my age I never had to deal with. It's a new phenomenon. To be able to redirect when they seem to be spiraling down into a non-therapeutic train of thought, or for them to be able to practice that and to have a discussion about okay, you felt that, that's valid. Here are some things that we can help you with that might be useful for you as you care for these types of patients.
It is such a hard thing to even imagine, because it's always such a sad thing. What were some of the reasons?
Right, we did look at some of the risk factors, and definitely, several of the kind of larger categories are previous mental health disorders. Previous suicide attempts were a very large risk factor. Personality characteristics when it comes to impulsivity or poor coping mechanisms. Suicide in their family, or even more recently, contagion, where kids may a suicide attempt in their school or with someone they know. It may help kids think that, oh, this is a viable way to cope with my stress. Those are all kind of risk factors for our teens today. And with the advent of social media, a story doesn't just kind of stay in the community within the grade of where the student is, but the stories can spread like wildfire. So I think that that's definitely a stressor that I never experienced as a youth.
Also having access to the means. A lot of kids have access to guns. Sometimes under pressure, they try something new to get high. They don't realize the consequence. Sometimes they don't need to kill themselves, and they're just trying something, experimenting, and then unfortunately it leads to self-injury.
And then, as we were looking at risk factors, we were also looking at protective factors. We generally think of them as, personal protective factors, and then more community-based protective factors. personal ones include, like, are they involved at school? Do they have good coping mechanisms or problem solving? Do they have a good sense of self-esteem? Those are protective factors kind of innate in the individual, but also protective factors in connection with their family or in their community. Are they connected with people at school, whether it's teachers or students? Do they feel supported and safe in their families? Are they engaged in something that gives them purpose, whether it's religion or a school sport, a job, or specific cultural aspects? Those are all things that give youth a sense of self-esteem and can mitigate some of the hopelessness that they might feel if they have these types of supports.
Do you deal with the family?
And it depends. Yes, we do. In pediatric world, you are dealing with the whole family, is not only the patient. Through this project, actually, we developed a lot of resources. We collected a lot of resources for the family education. Unfortunately, sometimes the family can be the source of the problem. Those are the cases that we limit the visitations. Our psychiatric team will sort out who can come and go. But in cases that is new to them and they didn't realize it, we try to be their support. Our psychiatric team is really helpful in helping us to give them the resources they need.